So we're going to start off, we're going to talk all about the kidney. So here we have the kidney and it's coming around. This is all blood supply. We'll label these different parts of the kidney as we go. And typically you'll see the kidney drawn more like this. But for our sake, what we did is we folded it out, made it like this. So it's a little bit easier to understand. So right here we have the proximal convoluted tubule. Right next to it we have the proximal straight tubule. Spelled that like George Strait. There we go, it's a little bit better. With the descending tubule, ascending tubule, we have the distal collecting tubule. Right next to that we have the macula densa. We'll talk about this as it's an important part. And then lastly we have the collecting tubule. Alright, so I'm going to draw these cells. They'll look just like this. You're going to need one for each here. Okay, so we're first going to talk about proximal convoluted. And there's a lot going on here. So we have HeO3 coming in here. And we have a lot of these aquaporins. So these are not HeO3 is not allowed to, it's not permeable here. So what it can do is it can change over and turn into carbon dioxide and water. And so water is available through aquaporins to flow through here. And over here we have, this is where the blood runs. So this HCO3 can run here as an aquaporin into water. This carbon dioxide is able to flow across the barrier, but the carbonic anhydrase is not allowed to. We also have other cells that are butted up against it, and different things can flow right through here. So we have paracellular or transcellular. So this transcellular would be across, and this is para. But here we have this flowing across, and this could be calcium, chloride, sorry, not chloride, potassium, and water. We call this solvent drag. It brings these solvents across through this water channel in between. in between the different cells. Okay, we have a few more things going on here. In the proximal convoluted tubule, we have a few transporters, and they all use sodium. So we have glucose, and this will transport 100% of glucose. And then we have amino acids. They'll transport 100% of amino acids. And we have lactate. Remember, they're all bringing in sodium. Sodium is really important in the kidney. So as we've talked about this a little bit before, we have this carbonic anhydrase, and we have carbon dioxide plus water. So in order to get this out of the cell, the transporter that will bring sodium, sorry, I drew my arrow wrong. Oh, will also bring sodium out of the cell. And then we have, because all of these are able to flow outside the cell, which glucose is a special situation. It's only allowed to reach a certain point. We call this renal threshold, when it's only allowed to absorb a certain amount. So you'll, as you'll learn more about things like diabetes, it's because they are not, your reabsorption is blocked, and so what you end up having is you end up having glucose in the urine, which is not the most ideal circumstance. So we're going to move on to the proximal straight tubule. So when you think of proximal straight, you should think about chlorine. So we have, once again, sodium coming in, kicks hydrogen out. So we can use any anion with a hydrogen proton to move in. This will separate hydrogen anion. And then once again, we'll use this anion to come back out of the cell and use it to bring in chlorine. This chlorine can then go through the cell in this channel called CFTR. Next, we'll move on to the descending tubule. And as we move down the descending tubule, we'll change our concentration gradient from 300 to 600, meaning the farther you go down, the more water you lose, the more concentrated it is. And so, something I forgot to mention here is in the proximal convoluted, we have 70% of water and 70% of sodium. And why I say that is because right here at the descending tubule, this just focuses on water, even though it only does 20% of the water. So we just have these aquaporins where water can flow, and we also have, we talked about before, we have a sodium potassium pump, keeping this concentration gradient, and so forcing us to lose out on some of that sodium making it outside the cell. Next, we'll move on to the ascending tubule. So the ascending tubule difference about the ascending is it is not soluble to water. So water cannot move through here in between the cells, nor is there aquaporins here. But we have a special channel here that lets all these ions in. So we have sodium, potassium, and chlorine. And this moves from a concentration rate of 100 to 500 as we're losing these ions into the other side of the cell. So we have potassium weak channels, and we have our sodium potassium pump. Next we'll have the macula densa. We'll talk about macula densa in a little bit actually. And we'll have the distal collecting tubule. The distal collecting tubule and it works in connection with the collecting tubule. But once again, we don't have water permeable here. What we do have is as mainly sodium goes through here, it works through, and we're able to tell how much sodium is inside the cell. If there's too much sodium, we release something called Otherstone, and too little, it's called nitric oxide. And I'll teach you about why that matters here in a second. We move past the distal collecting tubule. Sorry, it's just a collecting tubule. We have sodium coming in, potassium coming out from potassium weak channels. And then we have this G-binded protein receptor called ADHR. And as our ADHR is activated, we also have this aquaporin channel in the center. And so as this is activated, as this activates, it activates this aquaporin channel. This aquaporin channel will create aquaporins here that will run straight through and go into the blood. What this will do is this will help us create a concentration gradient. Start at 100, go down to 600. A little bit more dilute, which will help us regulate our blood as it goes through. Okay. So now we're going to talk a little bit about filtration. I drew something like this before. So we have first fenestrated capillary, and it's full, it depends on the size. Underneath it we have this basement membrane. And the basement membrane acts as a filter through size and charge. This is nitric oxide. Oh, sorry, no negative charge. Not nitric oxide. It does not allow negative charges to pass through it. The next filter here is our podocytes. That also filters by size and charge. And lastly, we have the mesangial cells, which are smooth muscle. And so now we're going to talk about, so we talked about this adenosine and nitric oxide before. So we have something called GFR. And GFR is the rate of filtration. So GFR and blood pressure are highly correlated. We have on this side, we call this the afferent. This is the efferent. Blood vessels. We have high blood pressure. We have a higher GFR. We have higher chloride. Here we use macula densa to produce adenosine, to produce vasoconstriction. So when I drew here, right, this is actually the macula densa. I know I said that it was the distal collecting tubule, but I just drew those in the same thing because they are within the same realm. So we have it the complete opposite way here. As blood pressure is down, you have a lower GFR. Lower sodium chloride produces nitric oxide, causes vasodilation. Helping us to increase our filtration rate. Okay, and with this we have something we call clearance. So clearance equation for clearance is P of X volume. So the volume in the blood, the urine concentration, and the plasma concentration. Our problem with this equation is that as something goes through the kidney, this blood runs all the way through here, something can be absorbed and resecreted. And so this equation does not work perfect. Instead, a better way we can calculate clearance is equals GFR plus secretion minus reabsorption. So we draw out this graph, urine concentration, protein concentration. So creatinine is kind of our good good example of what's happening here, because it is rarely secreted or reabsorbed. In a perfect world, that's exactly what will happen. So over here, an example is PAH. PAH is filtered and secreted. And so, as you can see, it does not follow that same trend. We end up having more in the urine than is in the plasma, not keeping the clearance within the same realm. Here on glucose, we should never have any in the urine, but what we talked about before, we have this renal threshold. Where we hit a max and we're not and we cannot keep it within the plasma anymore. We start secreting it through the urine, thus creating some problems. Okay, and then we also have another cycle for regulating this with, I guess not with this, but with GFR. So we have renin. As GFR is down, rate of filtration is down, renin, the production of renin goes up. That produces angiotensin 2. Angiotensin 2 produces aldosterone. And what that does is it moves potassium across the cell. As potassium crosses the cell, I'll draw any of these. Oh, there's one. Okay. As potassium moves across the cell, there's lots of potassium. If water is able to flow, it will flow that way towards our blood vessel, causing us to have an increase in blood volume. Increase in blood volume. We've also talked about it before. Angiotensin II also produces ADH, and ADH works with baroreceptors and osmotic receptors in the brain. To bring up blood volume. Angiotensin II also just increases if vasoconstricts to increase blood pressure. Alright, and the last thing we're going to talk about here, I'll draw this again. Down, comes up, comes back down. So we have different concentration gradients coming across here. The other thing we have is we have a blood supply that comes down, up, around. So we have these different concentration gradients. Draw them as dashed lines across here. See how you need. So we have these different concentration gradients. On this side, over here, on the straight tubule and descending tubule, this is permeable to water. Over here we have a couple channels. These are permeable to ions. So we have ions leaving. And we just talked about ADH and how ADH affects our volume. And so ADH has the ability to open aquaporin channels over here, allowing for this concentration gradient to change. So we start here. We start in the realm of 300. We can see there's 300 around it. And as we come down, this water is going to leave. I'm going to head towards the blood. Because it's permeable, we're going to continue and keep it right with the water. But it's soon going to change awfully quick because, as we can see here, we're not permeable to water anymore. It's not able to diffuse in and out. But we are guaranteed we are losing these ions. So we have 600 milliosmoles. And quickly we're going to go 500 and a 400, 300, 200. We'll get all the way to 100 up here towards the distal collecting tubule and the macula densa. And depending on the amount of ADH released, we will be able to come back down and be able to match it as this water flows in and out here. And I mean, this all depends on those aquaporin channels that are open. Because if they're not open, then we will continue in the concentration gradient and be able to stay at a higher concentration than the outside. And yeah, that's the kidney.